kidney stones is a common problem in the community. In 100 students MBBS class, at least 5 to 6 stone forming classmates will be there. Neolithic classmates will always be there. Okay, nephrolithic classmates, sorry. Now, what is the site of obstruction? A stone commonly obstructs between the ureter and the vesicle. Uretero-vesicular junction is the place where stone latak jayega. Calyx of the kidney, uretero-pelvic junction, intersection of the ureter with the iliac vessels, which is the narrowed, constricted part of the ureter. There are other locations where stone can lead to development of obstruction. What is the main risk factor, doctor? Low fluid intake is most common preventable risk factor. But if you take high fluid intake, you will become primary polydipsia case. If you take low fluid intake, stones ka problem. Normal fluid intake, your kidney is excreting excessively. Life is miserable. Now, the second thing is family history. Third, there are some conditions which precipitate stones. Gout, Crohn's disease. Why Crohn's disease? Crohn's lead to involvement of the gut. Inflammatory bowel disease. Inflammatory bowel disease will promote oxalate stone formation, and that lead to development of calcium oxalate stones. Then hyperparathyroidism. What will PTH will do? It will drag all the calcium out of the bone and make it lost into urine and increase the urinary calcium levels, and that lead to development of kidney stones. Hyperparathyroidism. Already we discussed. Type 1 RTA, which is basically what? Distal, not proximal. Useless terminology. There also there is a stone forming tendency is what need to be remembered. Loop diuretics, furosemide, what will it be doing? It will be losing the calcium into the urine. Calciuresis it will promote. Similarly, acetazolamide, what will it do? It will inhibit the carbonic anhydrase, and inhibition of carbonic anhydrase will create what kind of pH to the urine? Alkalotic pH or acidotic pH? Which promotes the stone formation? Alkalotic pH to the tubular fluid, which promotes the calcium stone precipitation. Similarly, antacids, they are also another important cause. Leukemia like conditions where there is an increased cell turnover, or if you are giving chemotherapy to the patient where the cells are destroyed and release of urate occur, and that lead to urate nephropathy, are the various precipitating factors. Similarly, males have a greater tendency. Urinary tract infection, especially with the urease producing bacteria. Which bacteria known to produce urease, doctor? Proteus mirabilis will lead to development of struvoid stones which contain ammonium. Ammonium predominantly is what need to be remembered. Now, if you look at the types of stones, the most common stones are all calcium. They contain either calcium oxalate or phosphate or both of them. They are radiodense, very much visible on X-ray, and any entity leading to either hypercalciuria or hyperoxaluria precipitates the calcium oxalate and calcium phosphate stones is what need to be remembered. Urate are the second most common stones. Any hyperuricemic state or any cancer chemotherapy leading to destruction of the cells, leading to the release of the nucleic acids which metabolize to form excess uric acid, lead to development of urate stones. But urate stones by nature are radiolucent. They can't be picked up by a plain radiograph. Hence you need to use CT, ultrasound or intravenous pyelography in order to detect the urate stones. Then you have this kind of a huge, big stone which will almost occupy the entire pelvic ileal system, which is called struvoid stone, which accounts for 5 to 10%. It is also radiodense in nature. Proteus, Klebsiella, Serratia, Enterobacter, they are all the urease producing organisms which lead to the formation of the struvoid stones. Any alkaline urine with a urea splitting bacteria producing the ammonia is a right environment for the struvoid stone formation, and that released ammonia will bind with magnesium and phosphate. So ammonium, magnesium, phosphate combination will constitute what is called as the struvoid calculus. 1% of urinary stones are due to cystine. They are typically hexagonal shaped as what you can see, and genetic conditions like cystinuria typically lead to the formation of the cystine stones is what I want to underscore to all of you. Now doctor, what is the clinical course of the stone? It all depends on the size. If the stone is more than 1 centimeters, it is unlikely to pass spontaneously, and anything less than 0.5 centimeters, 50 mm, can easily pass spontaneously. Recurrence is very common. About half of the patient will have recurrence within 10 years. There is another sad story, unfortunate story about the stones. Now, what lead to hyperoxaluria and hypercalciuria? Any excessive absorption of calcium or decreased kidney excretion, decreased renal resorption or increased renal excretion of calcium can precipitate hypercalciuria. Any increased bone resorption or primary hyperparathyroidism. Similarly, sarcoidosis. Why sarcoidosis? Typically, sarcoidosis is a non-caseating granulomatous inflammation, and granulomas contain macrophages. Macrophages release vitamin D like substance, and that vitamin D like substance will increase the calcium levels, and hypercalcemia, hypercalciuria and the stone formation can be the consequences of that vitamin D like substance produced by the macrophages. In case of the sarcoidosis is what need to be remembered. Then coming to the hyperoxaluria, anybody who has got a steatoria, whatever be the cause, can you give me the reason for steatoria? Normally lipid is metabolized by the lipases produced by the pancreas. Any pancreatic exocrine insufficiency can lead to development of lack of lipases and lack of breakdown of the fat and losing the fat into stool. Steatoria can lead to the increased absorption of the oxalate, and that lead to development of calcium oxalate stones. Any small bowel disease, Crohn's disease, pyridoxine deficiency, any of them, because pyridoxine is one of the important coenzyme which is required in the metabolism of the oxalic acid, is what we need to remember. Now, how do the patients present? Renal coli, you all know. First clinical case presentation in the third year will be how to differentiate different forms of coli, which is the only coli which is not colicky in nature. Your postgraduates are nowadays not asking ragging questions in the ward rounds. Best person to learn as an undergraduate is first year PG, because he is more mature than a house surgeon and less pessimistic than the professor and more enthusiastic than a third year PG. So first year PG, if he goes into second year PG, he is like a hyper mature cataract. He is of no use at all. You can't see anything through him. So best is first year PG, very energetic. Chalo, unko pakdo, chai pilo, candy khilo. He will make you all essential secrets to pass exam and also MD entrance. Both the things he will be able to tell, because he recently came out in a puerperal phase after delivery. He is in first year. He is still secreting lochia, serosa, rubra and etc. of the entrance material. So he is the best candidate who always must be caught. Okay, doc. What is renal coli? Your PG taught you. It is a typical pain, groin, loin to groin is a typical pain. It radiates anteriorly towards the groin and follows the path of the ureter. There can be nausea, vomiting, hematuria in a good number of cases. Always, doctor, a male patient presented with hematuria means very common cause is UTI. Other cause is stones. Next cause which you don't want is renal cell carcinoma, bladder cancer, depending upon the age of the patient. Okay. Then stone itself due to obstruction can predispose to UTI. Even UTI can be a presenting feature of an underlying stone is what need to be remembered. There is a large Staghorn calculus involving the pelvic ileal system, a struvite stone fundamentally. So there is a sudden onset of colicky flank pain, urinal analysis will show hematuria, and it can be either microscopic or gross depending on where is the stone located, how much of injury it is causing. It can lead to bacteriuria, pyuria because of an underlying infection, and if you check the pH, if there is an alkaline urine, then think of struvite stones which are very common in an alkaline milieu. You should always send the urine for culture, 24-hour urinary sample to calculate the calcium levels, uric acid, oxalate, citrate and levels you need to calculate in the urine. And you also need to send a serum chemistry, because already if it is a very late case, then there would have been hydronephrosis with entire renal damage. Is it there? You need to get the baseline of urea and creatinine. Coming to imaging, in a patient presenting with stones, what is the first imaging technique of choice which you wanted to choose even in 21st century, doctor? A plain KUB, kidney, ureter, bladder film it is called. KUB is the one which you need to basically order, which is the initial imaging test for detecting stones. Only exception is those 1% cystine stones and 10% of those stones which are urate, they go undetected is what need to be remembered. Yeah, if still patient has money in his pocket, get a CT scan done. Otherwise KUB can be able to pick up. CT scan is very sensitive. See doctor, this is the liver, this is the intestine, this is the little spleen looking at you, and this is the right kidney which is alright, but the left kidney has got a huge large stone which is detected by your CT. So even the urate stones, cystine stones which are radiolucent on a plain radiograph still will be visible on the CT scan is what you have to fundamentally remember.